Good morning and welcome to our webinar on the role of the GP in blood cancer care. My name is Jenny Burke and I'll be hosting today's webinar with my colleague Linda and our invited guests. So the Leukemia Foundation would like to acknowledge the traditional owners of the Indigenous lands we are all attending from today. And I want to recognise their continuing connection to land, to sea and community, and pay deep respect to their elders past and present, and to their commitment to maintaining the stories, traditions and culture. For today, for those of you participating, just a reminder that the chat is live and you can add a question or a comment there. And we ask that all questions and comments are respectful and considerate. We'll save our questions for the Q&A session at the end of the presentation, and just remind you that we're unable to provide very specific or highly personalised advice. And for the best experience, you may want to set your screen to the speaker view. So to get going, it is common for people with a blood cancer to feel like their safety net has gone after intensive treatment finishes or when they leave the care of the hospital. For others with a chronic blood cancer or on watch and wait, you may not have that same connection to hospital care at all. So adjusting to managing your own health and recovery can bring up many issues and feelings. It's important during this time to find the key people who'll help you with your ongoing health and well-being. So today we're going to hear about the important role of general practitioners and the role that they play in supporting health and well-being while living with a blood cancer or a blood disorder. So this session is designed to offer valuable information to help you improve the way that you use and experience the healthcare system and foster a better relationship with your GP. And it now gives me enormous pleasure to introduce Harriet. Harriet was diagnosed with blood cancer in early 2018 and luckily has been in remission for almost 7 years. Since achieving remission, she's bought an apartment and travelled across 8 different countries in 9 weeks, all solo. And in other solo adventures, she's hiked Mount Kosciuszko in New South Wales and the Old Man of Coniston in the Lake District of the UK. Her best holiday ever was swimming with whale sharks on Ningaloo Reef in the WA. Beautiful Shark Bay region. She's the owner of a gorgeous cat and a strong-willed cavoodle. And on weekends, Harriet can be found watching the footy and instructing at her local dog obedience club, where her cavoodle pretends to be well behaved. So as someone with chronic medical conditions and as a person in remission from blood cancer, Harriet has learned how to navigate through our complex healthcare system, and she knows just how important it is to build strong connections with your health team, starting with your GP. So let's listen to Harriet's experience now. Thanks, Harriet.
Hi, so thanks, Jenny. I am Harriet, and you'll have to excuse my voice. It's a little bit croaky. I have a sinus infection and a cold. I may pause to cough, but hopefully I remember to mute myself on time. So as Jenny said, in early 2018, I was diagnosed with acute myeloid leukemia, which is a blood cancer, after feeling fairly unwell for a long period of time. I've been in remission since the end of 2018, but 2018 was a very full-on year for not only myself, but for my family as well. And I'm one of the very lucky ones that when I went to my GP with my symptoms and my concerns, she took me seriously and she did probably the best that she could do given the rather wide range of symptoms that I came to her with. I'm also very lucky that I have had the same GP since I was 18. And in 2018, I'd already been working with her for almost a decade at that point. So we knew each other very well. And when I came to her with my symptoms, which were the very generic ones, I was very fatigued. I felt sick after eating and after exercising. I wasn't sleeping very well, and I was always run down, always had a cold. Instead of just saying, I think it's stress, let's see if we can monitor your stress and bring it down, because I was in quite a stressful situation at the time, and a very high stress work environment. She said, let's get you some tests. So in about February 2018, I went through all of these tests and waited for the results to come back. Ended up calling the nurse at that clinic, who said the results all looked fine, nothing to worry about, just keep going. Put it in the back of my mind to catch up with the doctor again, maybe in a couple of months, see if I was still feeling unwell. 2 weeks after I got that call with the nurse, my GP actually called me and said, hey, why haven't you been in to see me? I've had a note on your file to say when she rings for her results, tell her she needs to come in. I explained about the nurse and was like, why do I have to come in? When I went in, it turned out that while all of my blood tests looked like they were in the normal range and my iron was fine, I was actually reporting as slightly anemic, which was very odd because everything else was fine. My GP then asked me some more questions, and as part of that, I disclosed that I was bruising randomly, even if I just scratched an itch. My GP is very good at a poker face. Most GPs are, but that one, the bruising, made her actually pause and say, we need to investigate this more. Let's refer you to a hematologist. So once I was referred to the hematologist, within about a month, I had been diagnosed with myelodysplastic syndrome, which for someone my age and gender is very uncommon. And then within that same month, it had transformed itself into acute myeloid leukemia. And I'd gone from the first hematologist to a second hematologist who worked out of one of the bigger hospitals in Victoria. Throughout this stage, I kept in contact with my GP fairly regularly to keep her on board, up to date, and just be like, my mental health is not great here. I think we need to come up with a mental health plan, which she was very on board with. And I've been talking to that psychologist since 2018 because of everything that's happened. Once my primary oncologist started to put plans into place for me to go into my first round of chemo, I stopped talking with my GP as much. However, I made sure that any test or any plan that my oncologist and my cancer team put into place was fed back to my GP. As I progressed through the treatment, which I'm sure some of you are way too aware of, 2 consolidation phases of chemo, which was very long, and I wish I will never see that ward again. And then the bone marrow transplant. When I wasn't actively in the hospital and wasn't partaking in their inpatient, outpatient day treatments, I did make sure I caught up with my GP just to keep her up to date. When I was finally officially in remission and I was moved from inpatient, very intense, ongoing treatment to the more follow-up maintenance remission treatment, I also made sure that I touched base with my GP a lot more throughout that. As I said, I'm very, very lucky that I had that relationship with the GP, that she was someone that I was comfortable making sure that I advocated for myself with her. When I was with my oncology team, I wasn't as confident and comfortable. So for me to have her as a safety net was immensely relieving for me, because it allowed me to have someone that wasn't in the oncology team, but who knew at least the basics of what I was going through, to ask questions to, and just make sure that that was actually the right thing. That, and I know, like, you have to trust your primary care teams to a certain extent. But having her as the safety net really helped make me more comfortable with everything that was happening with me. However, I also really know, because my brother is currently going through it for a different type of cancer, that a lot of people don't have that primary GP that they've built the relationship with. And often when, like with my brother, the first time they see that GP is when they go and say, I've got all these symptoms, and they get investigated. Or they've been to various GPs who have just been like, it's just stress. You just need to rest. You just need to do X. And then finally a GP hears you. From that, I'm currently teaching my brother to advocate for himself with every doctor that he sees. It was probably one of the most important things from my treatment and the whole process, was being able to advocate for myself. And it started with the GP, and it started way back even when I was 18 and I first went to see her. Because I was comfortable advocating for myself there, it made my journey a lot smoother, and certainly I believe contributed to my very positive overall outcome. I have ongoing chronic conditions that I work with my GP on as well, that are unrelated to the cancer. However, when we talk about them now, we always have that underlying what happened during the treatment with the AML, and then also everything else. Like, it forms that building block. So forming that relationship with your GP is very important, like very, very important. More important, I'd say, than forming it with your oncologist, because there will be a point in time where you are 3, 4, 5 years in remission, and then all of a sudden you go from seeing your oncologist 3, 4 times a year to once a year, or even, if you're like me and haven't followed up recently, once every 2 years. And things that would get covered in a late effects clinic, which I'm sure, depending on where your journey is, you'll hear the late effects clinic terminology used quite a lot. If that is slow in happening for you, a referral for that, your GP really will fill that void and help maintain your overall health while you're waiting for different aspects of the cancer care system to catch up. I've gone on like 3 tangents now, and I think I'm pretty sure I've gone overtime. So from me, it's so vital to build that relationship with your GP and to advocate for yourself. It will make your journey a lot easier, and it'll also make your support team, your personal, private, family support team's journey a lot easier as well. So, yeah.
Thanks, Harriet. I love that you raised the issue of family and friends at the end there, because I think they're such a crucial part of this discussion and often get forgotten. And I've popped a couple of your top tips in the chat, but I know we're going to be talking later with you as part of the Q&A. So thank you for sharing your story and for staying with us today. It's my great pleasure now to introduce Dr. Robert Menz. Robert is an experienced specialist, a general practitioner from Adelaide, so he's a little bit behind some of us in time and a little bit ahead of others. He also has wide experience in non-clinical aspects of medicine, and he is very involved in different organisations, and this includes representing the Royal Australian College of General Practitioners on the Leukaemia Foundation Blood Cancer Task Force. So let's chat with Robert now about the role of the GP. Thanks, Robert.
Thanks, Jenny, and hello to everybody. Thank you for your welcome to country. I'm speaking to you from Kaurna country on the beautiful Adelaide Plains, and we're very lucky to have had some rain overnight, first rain in a long time, and my thoughts go out to anybody in the country who is in an area where you've had far too much rain up in New South Wales, or you've had not enough rain in northern South Australia and parts of Western Australia and Victoria too. I've got some slides to share with you, so I'm going to put my screen on share so you can hopefully see what is happening. And here we are. So we're going to talk about the role of the GP, and that's not me, that's a generic general practitioner. So what's going to happen today? Well, I'm going to talk to you for about between 30 minutes, 45 minutes perhaps, about various aspects. I'm going to talk a little bit about blood cancer, but I think most of you know about that because you're going through the journey or you're with somebody who's going through the journey. I'm going to mainly focus, as Harriet has done, on what happens after the acute treatment. The term survivorship care is one I'm going to use. I'm going to talk in more detail about how to access chronic condition plans for your GP, and I'll explain this as we get there. Talk about shared care between the GP and the hematology or the oncology specialist treating team. Harriet's done most of the hard work, so I'll talk a little bit about how to engage with the GP and give you some more tips about doing that. I've been asked specifically to talk about regional, rural and remote, which is something that I know a little bit about, having worked in those areas, and a lot about having traveled to many areas, and I'll share some of that with you as well. And then we'll have time for questions afterwards. So there's me last week in the easterlymost point of this on the Australian mainland, which is about as remote as you can get from South Australia heading east. So Jenny introduced me as a specialist GP, and GPs who've got the appropriate fellowship have been known as specialist GPs for a while. But for today's talk, I'm going to use the term specialist to talk about those specialists who aren't GPs. So mainly hematologists, and I mainly use the term hematologist, but include the other doctors and clinical team that will be involved in have been involved in your care. I just want to tell you a couple of patient stories, and some of which will overlap with some of the things that Harriet said. There are about 20,000 new diagnoses of blood cancer each year and about 40,000 GPs. So the average GP is going to see a new blood cancer every couple of years. I've changed the names of these patients, but the stories are pretty much as they are, and they're just little vignettes. So Dean was 52, and he'd had Hodgkin's lymphoma in his early 20s, which had been successfully treated. So at the age of 52, I said to him, "You'd have to consider yourself cured of this condition now." The very next month, he presented with a lump in his neck. So he had a non-Hodgkin's lymphoma this time, which proved fatal for him some years later. Eva, actually, it's a little bit like Harriet's story. She was 45. She'd started working in the local children's hospital oncology ward the week before I saw her. And she had some bruising in the inside of her thigh, which is unexplained, and she had an acute lymphocytic leukemia, which was fortunately successfully treated. That was about a decade ago. I saw her last year, and she was doing very well. And Brian was interesting. He was 65, he'd just retired, and he presented with chest pain, which sounded very much like angina coming from his heart. Investigation showed he was anemic, and he had a chronic leukemia. So he went off to see the hematologist, had a low-grade chemotherapy for a while, transfusion. He was fine, had remission for 4 years. And he presented to me with a recurrence of his chest pain and said, I think my leukemia's come back. Over the years, successful several years, the intervals between him coming back proved shorter and shorter. And by the time he got to 2 weekly transfusions, he elected for palliative care and died shortly afterwards, quite peacefully. And there's some of the stories about patients, but I have a personal story to share with you as well. Some years after my wife died, I began a new relationship, and this was about 3 or 4 years ago. Anne had seen her GP the year before with vague symptoms, very much like Harriet had had, and all the blood tests she had then were normal. But then she also found a lump in her neck, which was the first sign of lymphoma. So, like many of you, I've sat alongside the anguish of uncertainty, the shock of being told this condition is treatable but not curable. The 3 weekly cycle of chemo recovery and just starting to feel better when the next round is due. Oh, not again. It's a familiar cry. Fortunately, Anne is doing quite well now in survivorship, although she has ongoing tiredness and brain fog, which I'm sure is a common symptom. The relationship, however, did not survive that illness, unfortunately, but that's another story. So, why is blood cancer important? Why are we here? And I'm sure most of you are familiar with these, but it was suggested I put one slide with some data in it. It's very common. There are many, many different types, and leukemia, lymphoma, and multiple myeloma are probably the 3 best knowns, but there are many types of blood cancer. I've mentioned that before, and not everybody makes it. And as with Harriet and as with Anne, early symptoms are very non-specific, and which makes diagnosis difficult. And the other thing, unlike other cancers, bowel and breast spring to mind, there's no screening. So early diagnosis is very important, and it really speaks to hopefully the skill of us GPs to be able to pick these symptoms for what they might be. It was great to hear that Harriet has done some travel, especially on her own. I was lucky enough not to be on my own, but it's important to think about. Oh, sorry, I talked about survivorship, and we'll come back to that. So that was in February this year. I was lucky enough to go up above that's in Steamboat Springs in Colorado. So I was lucky enough to fly above the snowy valley and enjoy a gorgeous day with lots of color and lots of beautiful scenery. Harriet, I hope you continue to share your travel experiences. So as Harriet said, she had very little contact with her GP during the active phase. And that's common, certainly in my experience of patients with blood cancer. Patients disappear into the hospital system and emerge sometime later. And again, if I'm lucky, and increasingly this is the case, I get a lot of information from the treating team in terms of letters and copies of results. So why else might I see the patient? Well, perhaps not while they're in hospital, although I have been known to visit patients in hospital while they're having their acute treatment. So they might get intercurrent symptoms as a result of some of the treatment and not be able to get into their treating team. Harriet alluded to the fact she's got other conditions as well, and patients who have, for example, diabetes or heart disease need ongoing treatment even though they're having active treatment for their blood cancer. 40% of patients presenting to GPs have a consultation which involves their mental health. So psychological support is something that GPs are doing commonly and often, And it's particularly important for patients going through acute treatment or even ongoing treatment for blood cancer, as it is for other cancers as well. Harriet also mentioned family, and the impact of family on such a diagnosis is profound. And often I've been in a situation where I've been supporting the families of the patient while the patient's having their acute treatment. The family's coming to see me to get some extra support. But here we get into what we're really about today, which is survivorship. So how is the GP involved? And I'm so glad Harriet went first, because she's done most of my work for me. So blood cancers, like any cancers, are considered chronic conditions. And there are management plans available, which I'll talk about in some detail in a minute. I've talked about mental health support, and I'll come back to that as well. The concept of shared care, I think, is really important. And I'll talk about a little bit about that as well. And I've certainly had patients who've had blood cancer who carry a card with them, which gives the phone number of their cancer nurse or their nurse practitioner, as well as the hematologist. And that's been really helpful in terms of treating acute symptoms. So a patient might come in, for example, just with a fever and nothing else, and there is a treatment path that is recommended in that situation. And so that's been really helpful. And of course, just because you have one cancer doesn't mean you can't get another. And so ongoing cancer screening for bowel and breast cancer, for prostate cancer for men, and of course, regular immunizations are really important. Although we do have to be a bit careful giving live vaccine immunizations to patients with active disease, because their immune system is severely, or can be severely, compromised. Now, this information is somewhat new, and I wouldn't be surprised if when you speak to your GPs about it, they wouldn't have heard about it, because although a change to the chronic disease management for GPs was announced in the 2023 federal budget, the details of this were only announced last Thursday. And so from the 1st of July, what used to be called a GP management plan, the name has changed now to a GP chronic condition management plan. And this, for both patients and for doctors and allied health professionals, is going to really simplify the system. As I said before, blood cancer is a chronic condition, so patients are eligible to be treated under these management plans. Once the plan is made, it can be reviewed after 3 months, and the ongoing reviews can happen every 3 months. And a patient who's had a GP chronic condition management plan, and their GP has claimed the appropriate item number for this, can have access to up to 5 allied health services annually. Currently, there's a much more complicated way of getting pre-approval from the allied health service provider, and that requirement has now been dropped to simplify the system. So it makes it much, much easier. And what sort of services might you have access to? Well, there are a number of areas that might be appropriate for people with blood cancer, including, as I've said there, physiotherapy, podiatry, exercise physiology, nutrition advice, occupational therapy. There's been a lot of criticism from the general practice community that these plans only allow 5 allied health services each year, but the government has chosen to not change that. And these are services which are Medicare supported, and some of the allied health providers choose to not bill a gap for these services, but that's a matter of discussion at the time. I'll come back to talking about costs a bit later. There are also access to allied health providers, sometimes through community health centres, sometimes through the public hospital sector, which will be at no direct cost to the patient. And these plans can be uploaded to My Health Record with your consent, which means that not only do you have access to them, but other treating doctors will have access to them. And these plans will include things like a list of your current medical problems, significant past problems, medications, allergies, and sometimes recent investigations. So it's very helpful if for some reason you need to see another practitioner. Mental health, it's just really so important. And I think I'm sure all of you would recognize that. And Harriet certainly talked about that as well. I hope that's okay to refer to you, Harriet, but as I said, you've done most of my work for me, so all I'm doing is filling in some of the gaps from my side of the fence. So it is, as I said before, a critical part of ensuring survivorship is to make sure that you have appropriate mental health support. And as talked about before, resilience is certainly an important part of this, and that's it's only a part of what we're doing, what we're involved with mental health. As I said before, GPs are often the first port of call for mental health support. There is no changes to the current plan or the current scheme with GP mental health treatment plans. And this again is a treatment plan that the GP can put together, which includes information about current mental health status as a mental health assessment as part of this plan, and some goals and targets for the patient to achieve and how that might be achieved. And they do allow access to referral to a psychologist. And the initial referral can trigger up to 6 psychological services. And then after review by the psychologist, a letter back to the GP can then refer for a further 4 services to make a total of 10 services per annum. Just a little break from all the slides with lots of words in them. This is another fairly remote area. Those of you who've been to the west coast of South Australia will recognise the jetty at Ceduna, which is about as far west in South Australia as you can get before you get to Western Australia heading west. And that was taken last year. Shared care. I did mention this before, and this again I think is a critical part of ongoing care, and something that isn't always done well. And it's really important that there is good two-way communication between the acute treating team of specialists, which includes, hematologists, oncologists, radiotherapists, and just to mention the medical staff, and the GP. And ideally, the hematologist will provide an ongoing survivorship plan or an ongoing chronic disease plan from the hematologist's point of view. And that will include things like how regularly you need to be seen by the hematologist or the GP, what sort of regular blood tests or other investigations might be needed into the future. And hopefully what will happen is, as Harriet has found, there'll be increasing times between when you need to see the hematologist, and ultimately, hopefully, the hematologist will be able to discharge you back to the care of the GP totally. I should have mentioned at the beginning that I'm talking about an ideal situation and things I hope would happen. And I recognise that it doesn't always flow quite as easy as this for a number of patients. One of the things that the GP can do is join a case conference with the treating team. And this again is Medicare funded for the GP. They are somewhat difficult to coordinate because they'll often occur at a time when the GP is not available or is too busy or is running late for whatever reason. But it's a possibility, and it's something that if you feel as though you're caught between your treating team and your GP and not quite sure which way to go, it'd be worth mentioning. Self-advocacy is so important. The Leukemia Foundation has a series of healthcare professionals who can be accessed for advice. And this is telephone advice, and the information about this is found on the Leukemia Foundation website. And these are trained healthcare professionals. Most treating teams will have a variety of different sorts of non-doctor clinicians, and they're called different things in different states and different things in different hospitals. But you can have blood cancer nurse coordinators. There are chemotherapy nurses if the patient's going through the acute chemotherapy. There are a variety of other support services often available through the acute treating team. What happens if you don't have a GP? Hopefully most patients will have a GP, and I think one of the points that Harriet made, which is really important, is that there is good evidence that continuity of care with the same treating general practice, and particularly general practitioner, does lead to improved health outcomes. And so if you can have a long-term relationship or develop a relationship with one GP, then that's going to hopefully lead to improved outcomes for you. So how might you find a GP if you don't have one? Well, you could ask. You could ask your family, you could ask your neighbors, friends, if you just moved into a new neighborhood. See what the other people are doing. If you, some patients might have a particular language or cultural backgrounds that mean that they would prefer to see a GP with a similar language or cultural background. And so there is often a community of people, a diaspora, if you like, which would be able to provide advice about who in the area might be able to do that for you. And I don't know if anybody's used Health Direct, but that's a good way of getting some health advice non-specifically. And they also have Health Director Service Finder, so you can actually go onto the website, which I've done here, and I've put in search by what service you want, and I've just used my practice postcode as an example. And that came up with a number of GPs in my neighborhood. So a few tips about how to get the most out of your GP consultation. And some GPs have said they groan when a patient comes in with a list, but I really like it when a patient comes in with a list. So one of the things you can do if you have got a list and it's got more than 2 or 3 things on it is to request a longer consultation time. Or if you think it's going to be complicated, if you've got 2 or 3 different issues, especially if they're major issues you want to discuss. And it's actually a requirement of the standards for general practice that general practices offer a range of different consulting times. List of questions and prioritize, because if it's a very long list, you might find there isn't sufficient time to get through it in a single or even a double consultation. So what are your questions, and what things do you really want to sort out today, and what things can wait till perhaps a subsequent consultation? And the other thing is that your doctor may well have different priorities from what the priorities that you have. And so ideally, the GP will amend your list to sort out the things that the GP think are really important to be dealt with today as well. They'll often overlap. Sometimes GPs will ask you to come back because they want to talk about some test results, or maybe there's a specialist letter that's come in from somewhere else. It's a good idea to make sure the GPs actually receive them, and the receptionist should be able to give you that information. Because sometimes test results or letters come back later than people expect them to. And if you've got a medication list, that's very helpful to have with you, especially if the medication has changed since the last time you saw someone, you saw your GP. Don't be frightened to talk about out-of-pocket expenses. Not only is having, especially when you have your acute diagnosis, it's virtually a full-time job being sick for the 6 to 12 months it takes to go through the acute treatment. But it can be really expensive. So don't be frightened to talk to your GP about his costs or her costs, the costs of investigations, the cost of seeing the specialists. And don't be frightened to speak to the other specialists about out-of-pocket expenses as well. An example might be if you need an MRI scan, that's usually not covered by Medicare for an MRI ordered by a GP or requested by a GP. But if requested by a specialist, another specialist, then it often is covered. Ask your GP for a health summary or a copy of your GP chronic condition management plan. And that's really helpful to have in case you need to see another doctor or to attend a hospital. And Harriet's really talked about this at length. As a specialist GP, I have to know a little bit about a lot of conditions, but the patients with their acute blood cancer or any other chronic condition, I try and tell them that they need to know more about their own condition than I ever will, because that's what's affecting them, and every patient is a little bit different. Feel free to bring somebody with you, partner, spouse, child, parent, whatever, depending on where you're up to in life. One of the things that happens that patients complain to me a lot is I rang up to get an appointment. I couldn't get to see you. I said, when did you ring up? And they said, this morning or yesterday morning. And I said, well, when you leave your appointment today, it's a good idea to make your next appointment. Most medications for chronic conditions, the GP can now provide up to 12 months on a prescription. But some medications only can provide a shorter period of time, and some pain medications often only once a month. And so if you know you're going to run out of your medication in 4 weeks from today because you've made your appointment today, make your next appointment for 3.5 weeks rather than ringing up on the day expecting to see your GP. A little bit about rural and remote medicine. I've already talked about that a bit. I was lucky enough to be in the Kimberley Coast last year. And these are the fabulous Mitchell Falls. I just put the name in because I'd forgotten that they were also called Punami Unpu, and it's important to acknowledge Indigenous connections to the land and using the nomenclature that the First Nations people have been using for thousands and thousands of years. So those of you who live in the country or live really remotely, I'm not telling you something you don't know. Care is more complex, and we're not only talking about blood cancer, we're talking about many conditions, but particularly for blood cancer. Patients tend to present later. It's harder to find a GP in many parts of the country. Health outcomes aren't quite as good for a number of reasons, and this includes delayed diagnosis, delayed treatment, access to treatment. It's very expensive to have to move from somewhere remotely in the country into the city, especially if you're having weekly radiotherapy, which is part of the treatment for some blood cancers. Most states have a patient-assisted transport scheme. It's called things slightly different in different states. This is what it's called in South Australia and several other states. And this doesn't provide a Learjet for you, but it does provide some support for transport, usually by bus, but it can be by air if there's no other public transport available. Some of you may end up with some sort of disability as a result of your blood cancer, and if you're under 65, you may be able to access NDIS, which will give you some more support for both transport and other ongoing care. And I think one of the things that's changed, especially since COVID, is the increasing access to health through telehealth. And this is not only for your GP, but perhaps you need a physiotherapy or an exercise physiologist program, but you live remotely and can't get to where the allied health provider is. They can certainly provide access, especially through video apps, video consultations, and also other apps that might be available to assist you. So you don't need to be living next door to an allied health centre to access this care. And I'm just going to talk a little bit about a pilot program that's happening in Western New South Wales called the Regional Access to Care for Haematology, or the REACH program. And this is a program which is supported or sponsored by the Leukemia Foundation. And it's clinics need to enroll. And the idea with this is it is a evidence-based decision support scheme, which is integrated into Best Practice, which is the name of one of the common clinical software programs that's used. And what it's aiming to do is use the decision support built into the system, I guess using some sort of artificial intelligence to look at potential blood cancer diagnoses earlier than the GP might necessarily have thought. Harriet's already mentioned that often people will go along to the doctor with non-specific symptoms and be told it's stressed or tired, is tired for other reasons. But the GPs can not rely on, but we can support it in making their decisions to hopefully get earlier treatment. And it's well recognized that earlier diagnosis leads to improved health outcomes as well. So not only does it allow timely diagnosis, but clear referral pathways as well. One of the other products or services the Leukemia Foundation offers are called optimal care pathways. And there are optimal care pathways for patients and optimal care pathways for doctors as well. And if you're familiar with these, well done. If you're not familiar with these, it's worthwhile being aware of it, because they are giving information about what the best pathway or the best care is available for your particular sort of cancer. And what if things don't go so well? And I think it's important to be realistic. We're not going to cure everybody with blood cancer, although hopefully survivorship will be longer and longer for most of you, if not all of you. So a survivorship care plan, I've really talked about this already, and this is a plan which is hopefully made in consultation with your hematology or acute treating team. We all should probably have an advanced care directive. This is really something which directs care for your loved ones or your medical treating team in the event you can't make your own decisions. And this is often done in people who know they've got some sort of potentially life-shortening illness, but there are plenty of people who are struck down acutely with conditions, traffic accidents, strokes, other things that make it impossible to make your own decisions. And if you've given some advice now about how you want to be looked after in the future, that's very helpful for your family and your medical treating team. Palliative care. Don't be frightened if your doctor suggests palliative care. A lot of people get confused between palliative care and end-of-life care, which is a small part of palliative care. Palliation really refers to symptom control, and the palliative care doctors are experts in treating symptoms, pain, shortness of breath, common nausea, common symptoms, both through treatment and through late-stage disease. things like lethargy and brain fog are harder to treat, but these are areas where if your doctor suggests palliative care, don't feel as though the doctor's saying this is the end of the line. And in fact, there are many studies which have shown that early referral to palliative care also improves outcomes and leads to increased longevity, which sounds a bit back to front, doesn't it? But actually, that's the way it works. As I said, end of life care is a small part of palliative care, and if you're getting to the end of your cancer journey and it looks like you have a life expectancy of less than 6 months, you have the option in all states now to opt for voluntary assisted dying. So that's really where I've got to. I didn't want to end on such a negative note. So there's always some light at the end of the rainbow, and that's a photograph of Granite Island, which I took last month down near Victor Harbor, which is about 80 km south of Adelaide. So thank you very much for listening to me. And I'll hand over to Jenny now to coordinate any questions for either for me or Harriet or for the team from the Leukemia Foundation.
Thanks, Robert. That was a really very thorough walk through, I think, a lot of what GPs have to offer that perhaps not everyone's aware of. And I think one of the key things that keeps coming up for me listening to you and Harriet is that it's a partnership.
Yeah.
So yeah, I'm going to hand over to Linda, who's actually collated the questions that people have sent in to us and also the ones you've dropped in the chat, just to expand on some of those points further. Thanks, Linda.
Thanks, Jen, and a big thank you to Harriet and Robert for that really wonderful overview. And I concur with Jen. I think we've all learnt something new today as well, even those of us who work probably quite closely with or have worked quite closely with GPs. I'm going to start with firstly acknowledging, and I think, Robert, you highlight this, that GPs have to know a lot about or know a little bit about a lot. So really, it's important that patients are able to come forward and with that information about their own illnesses and their own symptoms, and that patients, I suspect, are what we would say are the experts on their condition and on their own overall health. So it is, as Jen said, a real partnership. I'm going to start with a broad question around what do you, Robert, I'll direct this firstly to you. What are the frequently asked questions you get as a GP?
Oh, that's a really good question. And I think the first question anybody with a cancer diagnosis is, how long have I got? And that's a very natural question to ask, because cancer, certainly anybody who's my age or older, this sort of diagnosis when I was a medical student or a young doctor was usually a fatal diagnosis at the onset. And the whole landscape has changed hugely and continues to change quite rapidly. So the question of how long have I got is something that can't be answered at diagnosis by a GP. But certainly the experience I had with my former friend going to see the hematologist, he said, I obviously asked the same question, and he said, well, this can't be cured. You will die from it at some stage unless something else takes you off beforehand, but let's hope it's measured in years, if not a couple of decades. So that was a sort of ballpark figure. And for somebody who's 60, that's, if you get 20 more years, that's not too bad. Somebody who's 30, that's of course devastating. So I think that's a very common question. I think another common question is, so what's going to happen now? And so it's important that as GPs, we're able to map out the pathway. There's a referral to a hematologist. There'll be some further investigations. There'll likely to be blood tests. There's likely to be various sorts of scans. And people who've been through the journey will know the difference between a CT, an MRI, a PET, and some other ones I probably don't even know about. There's likely at some stage to be a bone marrow biopsy to help with the diagnosis if it's not obvious from elsewhere. That's a relatively straightforward procedure where a doctor under anesthetic, under local anesthetic, puts a large bore needle into either the hip or the chest bone and takes a small amount of bone marrow. So that's commonly done in diagnosis. And then there's the treatment phase. And the treatment phase, I guess if you take Harriet's example, is very similar. There's chemotherapy, which is often a 3-weekly cycle over 6 cycles. There might be radiotherapy involved, and that's commonly 1 session a week over a number of weeks, commonly 6 weeks again. Bone marrow transplant is a huge step, if you like, often successful. And I've had patients who've lasted 20 years after their bone marrow biopsy, and I've had patients who've died within a year. Increasingly, the former story is the more common one. So it's really important to have some sort of idea of the journey, and then reassuring the patients that that as their GP, I'm there, and they're welcome to come and see me at any time. But it's unlikely that I'll be seeing them for a little while until they come out of their acute phase.
Great, thank you. Harriet, did you want to add anything to that?
I think Robert covered it really well. I think the main question I had at the beginning for my GP was, is it cancer and what happens now? So yeah, Robert covered it very well.
Yeah, wonderful. Yeah, very common questions that we hear as well at the Leukemia Foundation. And I think also then that after the is it cancer and how long do I have, that those prognostic questions often, okay, so what tests and what happens now? Can I just talk a little bit, and Robert, you did allude to this in your presentation, but around access to GPs. And we know that's a real challenge for people, not just living with blood cancer, just generally in the community. Just wondering what people can do when perhaps when their regular GP, if they do have a regular GP, is not available. And I guess particularly thinking about people who have those really complex issues. So perhaps pain management, or seeking support around pain, around perhaps symptoms that are related to advanced disease and generally blood cancer, which as you just as you highlighted, that GPs often only see a new case of blood cancer, did you say once every 2 years approximately? So it's very unfamiliar to many GPs, but pain and complex symptoms are associated with those diseases. So yeah, just wondering what is, what's some advice that you can give if someone has to go to a different GP, a locum GP or an after hours GP?
Right. It's a really good question. The majority of general practitioners these days work in multi-doctor practices. And so if the usual GP is on leave or away for any reason, there should be a buddy. If the GP knows they're going to be on leave, they should, and the patient's there, they should look, the usual GP should say something along the lines of, I'm going to be away in the snowfields of Colorado for a month. And while I'm away, Dr. Jones is looking after all my patients. And I'll keep good notes, and I'll make sure that if you need to see Dr. Jones, that he's aware of the situation. If there's anything in particular, speaking from the GP point of view, if there's anything in particular that I think the patient needs to follow up with, I'll speak to Dr. Jones directly and say, Mr. Smith's coming to see you in a couple of weeks for this particular thing, and here's a bit of background. From a patient point, so that's in the same practice. If you need to see most GPs will actually fit somebody in who's got an acute problem, especially if they're known to have a serious problem like a blood cancer or other cancers for that matter. And so even if they can't see the patient directly, they'll often be available for phone advice initially, and then perhaps arranging an appointment in the fairly near future. Oh, something sent to my screen. Can you still see me okay?
We can, yeah.
Well, my screen's just gone funny.
Take a moment.
Yeah, well, I'll just ignore what's happening on the screen.
Okay.
I think the other thing is if the patient, if a GP can't see you, or say you're seeing a solo GP, or you're in an area where there isn't a GP, and you rely on locums coming into that area, and I'm thinking, well, certainly, probably everywhere in the country has areas like that. In South Australia, Eyre Peninsula is very much like that, apart from the three or four big towns. That does make it difficult, and so again, it comes back to ideally having a very comprehensive health and up-to-date health summary. So if as a patient, if you've got seeing a GP, and it's unlikely that that same GP is going to be able to be involved in your ongoing care,
Yeah.
it's helpful to have a complete health summary, as I've said, from that GP. And that should ideally also be on the patient record at that clinic, even if another GP has to take over.
Yeah, great suggestions. And we know that is the reality. In an ideal world, we'd love that continuity of care and to have GPs located in every possible point of Australia, but that's not the reality of our healthcare system. So that's some really great suggestions there. Wanting to just move into sort of talking more about complex needs, and I think we have already touched on that. And I think we could say that every circumstance when it comes to blood cancer would, perhaps be classified as complex, because blood cancer is a complex set of diseases. But wanting to find out a bit about how do GPs usually approach the management of a patient when they're confronted with perhaps a complex or rare condition, perhaps something like you said, we only see a blood cancer approximately every 2 years. What are the expectations of the patient and GP in that scenario? I think we've talked a bit about patient educating the GP. What are the first steps, I guess?
Well, I guess there's two parts to that question. I'll answer the first part from the GP perspective. One of the mottos of the College of GPs is the good GP never stops learning. So I have a patient coming to see me, and they've got a new diagnosis, and I often can't make the specific diagnosis, but let's say they've got some sort of blood cancer. I send them off to see a hematologist who tells me it's specifically this or that. And the classification of the lymphoma is something that I really haven't got my head around at all, except it's really complicated, lots of them.
Yeah.
I will then read up about that particular sort of lymphoma. I will carefully read the letter that comes back from the specialist, which will outline what the treatment plan is going to be, hopefully. And I'll do some separate reading about that. And there's lots and lots of information available on the website. There's lots of very good guidelines which are available. Some of them through the Leukemia Foundation. And I guess if I've got somebody with XYZ lymphoma, I should look up the optimal care pathway. I haven't had to do that in the last couple of years, but certainly they're available there. I think from the patient point of view, I think that the point's already been made, that the patient is really going to be the expert in their particular sort of blood cancer. And so it's going to be sometimes a joint learning effort. The other way that can sometimes happen is if there is a registrar, a training doctor in the practice. They might say, well, look, let's do a presentation. Why don't you do a presentation on this at our next clinical meeting? And that will inform the whole practice about that, and also inform the practice that the patient, the example of poor Mrs. Smith, that all the doctors in the practice are aware that Mrs. Smith has got this new diagnosis, and these are some of the things that we need to watch out for.
Great, thank you. Harriet, did you want to add anything to what Robert has said then about that education piece with your GP?
Yeah, I think it's very important that you don't just rely on your GP to know everything. There are so many different, even if we're just looking at blood cancers, there's so many different types of blood cancers and presentations within those blood cancers that while they may have heard about it, they're not going to be an expert on it. It's really up to yourself as the patient, and even from a carer perspective, to educate yourselves on what the actual problem is, so that where your GP may fall down from a specialized information point of view, you can kind of fill in that gap if it's required.
Yep. Yeah, absolutely. Can I just taking that a little bit further, and in lieu of the fact it's been several years since your treatment, and you have mentioned that you have other health chronic health conditions. Who do you consider is part of your actual healthcare team? So, sometimes we automatically think it's our doctors, but I guess what we're trying to do is broaden our perspective about who really is part of our treating team.
Yeah. So I probably do this a bit differently because I segment the different conditions, if that makes sense. Within every health care team that I recognize within my own mind, my GP sits rather centrally. But for me, I'm like the number one pillar of that support system. And then it's the GP, and then it's whichever specialists sit under that. But then it's also my psychologist who I've been working with. And when I was going and doing physical training, my PT sat in it as well, because I think people don't often recognize just how important it is to keep your body as physically active and healthy as you can, even while you're going through treatment. And I think this is just me, I think, but one of the reasons why I came out of the treatment for AML so well is because I was forcing myself to stay semi-active while undergoing the treatment, like post bone marrow transplant, except for the first couple of days where I literally was in and out of sleep and couldn't actually stay awake. And a lot of this comes down to my family, who also form part of my support team as well. My parents were like, right, you look like you're fairly awake. Let's get you up out of that bed and we're going to do laps around the ward. And so I think because I got up, I was moving, I wasn't just in the bed, maintaining my physical movement wise really helped a lot more than if I just stayed. So my PT, when I'm doing it, forms a very integral part of my support system.
Yeah, I think you really highlighted then that, one person, one GP can't be everything to you. you know, and that's the reason why we have special people who specialize in particular areas, because there is so much to know about the human body and the human mind, and so we go to different people for different needs. And so we need to look really broadly at who our treating team is. And that might be our family and friends as well as part of that support system. And they're often the ones that are observing our symptoms and our mental health, and are often the people who are first noticing perhaps changes that are occurring. So they really do need to be on board as well.
Linda,
That's,
can I just add something there? And I
yeah,
think
sure.
it's raised a really good point that I meant to mention during my talk, that the general lifestyle factors that we talk about with all patients are really important during blood cancer treatment. And so lifestyle, which means I'm talking about not smoking, about limiting alcohol, about regular exercise. And I say that with some trepidation because sometimes people are just too exhausted to exercise. But once you've got a baseline of exercise, then you should be able to increase that by 10% a week, hopefully. So if you can walk for half a kilometer, then in the next week you can walk 600 meters and just gradually build it up like that. And good nutrition is also really important. A diet that is strong on grains and greens, some protein, and again minimizing the sweet things. But that's general advice that applies to the whole community. But it applies just as well to people with blood cancer and blood cancer treatment. And again, there's good evidence that maintaining physical fitness and physical form does improve outcomes. It also helps mental health because regular exercise does as well for people with depression as do the standard doses of the antidepressant medications. I'd much prefer to go exercising than take pills if I'm feeling down.
Yeah, very good point. Absolutely. The GP plays a critical role in that general health management. And also, you know, it's important that we're highlighting that for our carers who are in the audience as well, not just the people with the blood cancer, the people who walk alongside them. Wanting to move on to some questions around communication and information sharing. And I think one of the challenges we hear is that communication between, and I'm sure you hear it too, Robert, is around communication between the specialist and the GP, and the patient sits somewhere in the middle of the two, often being the conduit at times, and sometimes the message sent isn't always the message received. So in terms of that communication loop, and how do we close that communication loop? What are some things that we can reasonably expect from GPs? And what can a patient potentially expect from their specialists, and how the two GPs and specialists can work together?
That's a really good question, and I think as GP, I'll sometimes contact the specialist directly and say, hey, look, I've referred this patient to you. I haven't heard anything for 12 months. What's going on? What's the plan? I often do it a bit more discreetly than that. But let me tell you a story to highlight how bad communication can be. The second patient I told you about was the first one. The first patient I told you about, Dean, with the recurrence of his non-Hodgkin's lymphoma 32 years after treatment. I've been treating him for about 25 years since he came to Australia. He was from Holland, where he had his initial treatment. I had treated his family. I had treated him through his acute heart disease. I treated his wife through her terminal brain cancer, which was the time he was going through his acute cardiac conditions. At the same time, he had a recurrence of his lymphoma. And the specialist admitted me to hospital for palliative care without any consultation with me or even notifying me. And the first thing I'd heard that he'd died was when I got a letter from the hospital, so your patient died
Oh.
last week. And if I'd known, I would have loved the opportunity to go and say goodbye to him, because it's somebody I'd known for a generation. So that's how bad communication can be, and I'm sure everybody's got examples of how bad it can be as well. So I will, if I haven't heard, I'll certainly contact the treating specialist either by phone or by writing, and I'm somewhat proactive in terms of doing, I think, but a lot of my colleagues do similar things. Even if you're able to, I haven't done this for some of the blood cancer, but I have for other conditions, gone and actually met with the specialist, sat down with them at a case conference or clinical meeting and gone through some of the issues. And I think that the idea of having a survivorship plan is something that's increasingly accepted by the specialist community in terms of assisting us GPs and looking after our patients.
Yeah, they're a very important document, and we do hope that they, are getting utilized more and more, because I think people do talk about that gap, and particularly after acute treatment, and then that sometimes we call it people drop off a support cliff, so to speak, because there's that and then there's nothing, and we need to try and bridge that gap. And I think survivorship care plans are a really good way of doing that. Knowing we don't work in an ideal world and that things do break down from time to time, but certainly they're a good mechanism for trying to improve that communication loop. Moving on to, actually, before I do move on, Harriet, did you want to mention anything about what worked really well for you in terms of communication? I know you highlighted you had a really strong relationship with your GP, but were there any things that really helped optimize that communication with your GP or with your specialist?
Yeah. So from like a personal perspective, I was hit very hard with the brain fog that occurs post chemo and post bone marrow transplant. It affected my short-term memory. The chemo did significantly. So I've kept them. I always had, and I think it was Denise maybe, I always had a notebook on me and a pen where I could write down any questions that I wanted to ask either the specialist or the oncology nurse or my GP, and I had separate pages for each of them so that I didn't get confused. And then as I was in the appointments, I'd just write everything down, because if I didn't, I would forget. And that was not a good thing for me. Mentally, I needed to know what was going on. And so writing everything down became very, very important. I also know that some people, if the GP or the specialist agrees, will record it with their phone so that they've got that verbatim recording there. I like writing and need to write it down so that I remember it better. And definitely booking appointments in advance.
Yeah.
I think my GP is amazing, but so do a lot of other people. So she's very busy. So anytime I have an appointment, I always make sure I have another appointment in reserve. And I always leave enough time for that appointment in my day, like my schedule for the day, because I know that without fail, she'll be late. And sometimes you just have to give people that grace, because you don't know what she has been dealing with or the other doctors have been dealing with earlier on before you. And you're not always going to
Absolutely.
be the one that gets all of the bad news that day. So, yeah.
Yeah, some great suggestions. And just adding on even to that, just note taking, even there's lots of great tech applications that you can use now in your mobiles that, you know, you can record questions and symptoms and test results or your medication list. So, you know, those devices can be really handy to aid in that communication. Thanks so much, Harriet. I wanted to ask about escalation of concerns. So, one of the things that we do hear about working on the ground and connecting with people with blood cancer, particularly those people who live in the community and are chronic and who don't perhaps have that same level of connection to a hospital. You know, what would trigger a referral back to a hematologist for advice about blood cancer management? You know, particularly for those people who are watch and wait, have been living in, or remission, or, you know, many years in survivorship. What would be the triggers that would warrant a referral back to their treating specialist?
Yep, another great question with lots of different answers. I think the first thing is just something obvious turns up. Somebody's in remission for lymphoma and they turn up with a lump in their neck. So that wouldn't involve an initial referral. It would involve an investigation initially. So I would get some basic things done. So that means the trip to the specialist is much more efficient because they've got some basic information already. That would involve a minimum of an ultrasound, guided biopsy, and some blood work. So that sort of thing's fairly obvious. Or somebody with leukemia who develops spontaneous bruising again. So recurrence of symptoms which are fairly indicative. I think the other thing it's much harder is when somebody's got very non-specific symptoms. They come in, they're a bit tired, they're a bit depressed, they're a bit anxious. They're just a bit concerned about their memory. The trigger for me for being concerned is progression of symptoms. So if somebody comes in and they have a set of symptoms and I say, look, I think it's this, why don't you go away and try these things and come back and see me in a couple of weeks and see how it's going. And if they don't turn up again, I've got to assume that they're feeling better. Hopefully they will turn up and say they're feeling better. But if they come back and they feel worse, so the symptoms are occurring more frequently, more severely, with greater frequency, so a progression of symptoms is always a trigger for me for increasing concern, early investigation, and referral if necessary.
I'm just reflecting on talking about progression, and, you know, often one of the very common experiences for people living with blood cancer is that fear of recurrence or fear of progression, and that need for heightened surveillance that comes with often that fear. How do you manage that with your patients? And Harriet, even from a survivor's perspective, how do you manage that fear from a medical perspective, and from a psychological perspective, perhaps?
Yeah, again, and that is, that is really common. Because once people have had a diagnosis like that, and if they say their first symptom was, well, like my second patient I talked about, angina, at least he was pretty pragmatic. His angina came back and he said, okay, it must be back. I'll go and do something about it. But a lot of patients aren't quite that pragmatic, and it is very common to get particularly anxious if the symptoms are occurring. And sometimes and if I'm fairly sure that these symptoms are not related to recurrence of the lymphoma or the blood cancer, whatever it is very time consuming, but very important to have that discussion in detail with the patient, because it's often a lot more difficult to try and be reassuring than it is to say, oh, we'll go and get a scan done, because I can fill out a form to get a scan done in about 30 seconds, and it takes about 10 minutes to have the conversation about why it's not necessary. And I think experience helps, because it's interesting looking at I do some registrar training as well, so I watch the young doctors consulting, and they appear to be much more ready to head off for investigation than to take the time to explain why it's not necessary. And the problem is, if you do that often enough, every now and again I'll get it wrong, and that then swings the pendulum the other way. Anyway, that's how. But I certainly think it's really important to acknowledge that anxiety or that concern, and I do that with my patients. I say, look, it's common to feel like this.
Yeah, absolutely. And I think you're right. I think that that the most important prescription for that immediately is to start to have that conversation around, what is physiological and what is perhaps some psychological elements as well. And often that time investment at that point often helps to set up a much more a better way of coping with some of that anxiety. Harriet, did you want to make any final comments about that before we wrap up?
Yeah, it's interesting because I'm by default quite an anxious person. And I guess for like the first 18 months post achieving remission, I didn't worry about any sort of relapse or return of the AML. And then all of a sudden, it just hit me. And I got almost to the hypochondriac stage of something's going to happen. I feel like it's going to come back. And the only thing that really helped was discussing it with my GP and discussing it in terms of, this is how I'm feeling. It might be irrational. However, that doesn't downplay the fact that this is how I'm feeling. And again, my GP, brilliant. She took it from the perspective, so what if it did happen? What would the steps be that we would take to deal with it? And we outlined it. We came up with a plan, and ultimately for me to feel better about, that I was actually okay and I didn't need the safety net of being in the hospital all the time for my treatment and my ongoing care. Talking that through and coming up with that plan was just really, really good. And then I was able to take it to my psychologist as well, because anytime, and like, you've got to love your carers and your family and the people around you, but a lot of the time they may not want to consider what does happen if it does come back. And so they'll be like, don't worry about that. That's not happening, so don't worry. So being able to have it as a serious conversation with my GP was brilliant.
Yeah, thank you for that, Harriet. I think, what both you and Robert said, and I think Caroline in the chat also really highlights just that need to be seen and heard and validated that this is a real experience, is really one of the key elements of dealing with the anxiety that comes with that. We are at time. I'm actually a wee bit over time, but it has been a wonderful conversation, and we could continue on with this conversation for hours, I'm sure. But I do want to thank both Harriet and Robert for an incredibly insightful, warm, and I think, as Jen put it, walk through how we, work with and engage with our GPs, who really are an essential part of blood cancer care. So thank you so much to both of you for sharing both your personal and that professional perspective. Jen, I'll hand over back to you just to close us out for today.
Thank you. I agree. It's been an incredible amount of information. It's been a warm and wonderful conversation. I thank everyone for attending. We really couldn't do it without you, and it's made all the better by your feedback and your questions and your comments. So for all of you here today, please use this information to start conversations with your healthcare team, with your family and with your friends, and use it to guide your ongoing health and recovery and quality of life if you don't see recovery as part of your future, but want to have a really good quality of life, because it is possible. So if you have any concerns or questions, please call us 1800 620 420. Talk to a health professional. Don't struggle on your own. We don't want you to do that. Our recording of this will be on our website very shortly. So if you want to rewatch it, refresh your memory about anything that was said, you can do that. And you'll get a short email that's asking for feedback. And we would really genuinely love to hear what you think and more about what you need. So thanks everyone for attending. See you next time. Bye.